Now, now I invite Dr. Akshyaya Pradhan from KGMU for talk on ESC Heart Trial Update 2025.
Thank you, Chairperson. And I think since we are running behind the schedule, I'll straight away again delve on a difficult topic. Hot trial updates from ESC. Now there are at least 50 to 60 trials presented, and it's like choosing one trial and choosing another trial as if I'm doing a step fatherly attitude or step fatherly attitude to a trial. But at least some good trials which will be of will be importance to clinical practice I've selected. So I've divided into sections of dyslipidemia, heart failure, ACS, miscellaneous, and selected 10 trials which I thought would be essential or would be far right changing in practice. So first trial is a trial on hypertriglyceridemia. You know, in our country, the most common form of dyslipidemia is low HDL followed by high triglyceride, where the LDL generally is low, or at least it's low compared to the Western population. So here is a molecule which is a ApoC3 inhibitor called as olezarsen. It's an antisense oligonucleotide. Basically, it goes to the liver and switches off the mRNA, which produces ApoC3. And ApoC3 is a key factor for production of triglycerides. So the beauty of this injection is that it has to be given only once a month. So there was an initial small trial published last year, the TIMI 73A bridge trial, where they used the molecule in 154 patients. It was primarily a phase 2 trial to find the correct dose and establish the preliminary safety. And there in this study they found that almost 50% triglyceride reduction they are expecting with the molecule. So this year they published a large trial of 1400 patients with moderate to severe hypertriglyceridemia. Again, since the doses were already decided from the previous trial, and they also took patients, if your TG was not very high, then you also it enriched your cardiovascular risk by taking established ASCVD or diabetes. That means either your TG was very high, if your TG was not very high, your CV risk was also high. And they again used the previous used doses 50 and 80 given every monthly. Again, the primary goal was to see in a larger population how does the molecule fare, does it give the same results as it gave in the preliminary trial. And you can see the average TG level was not very high, rather most patients were of moderate hypertriglyceridemia, but more importantly almost everyone was on statin and almost one-fourth were on fibrate. Still their triglyceride levels were very, or you can say moderately high. And as expected, almost 60% reduction of triglycerides we can achieve from the baseline at 6 months. And not only triglycerides, ApoC3, non-HDL, VLDL, remnant cholesterol, other parameters which apart from LDL can also be expected to be reduced. And almost all patients achieve their triglyceride goal of less than 150, which is the guideline directed goal. And of course, this was not a CV event trial, but we were looking at pancreatitis because any new molecule which works on the liver has the risk of producing pancreatitis. Pancreatitis was not significantly higher, and cardiovascular events again was not significantly higher, and the drug was also safe. So this gives us a, of course, this trial did not took patients of very high TGs, but still there are two longer trials and patients with high TGs going on. So in this population of with this new injectable molecule of once monthly injection, ApoC3 antisense oligonucleotide, we can expect a 70% reduction, 60% reduction in TG and 70% reduction in remnant cholesterol and ApoB non-HDLC, and it was a very safe molecule. So apart from LDL, if you are looking at other parameters, then this is a good injection coming in practice. CETP inhibition has already been for the past 30 years is been in disrepute because most of the molecules which we discovered, textbook says they were toxic, they never worked. But the problem with the CETP inhibition was we always tried to increase HDL with CETP inhibition, whereas the actual goal of CETP inhibition was to lower LDL. And this we found out from genetic studies that if you try to increase HDL, CETP inhibition is not working. But if you find a good CETP inhibitor which actually lowers LDL, then that is going to be helpful. So this obicetrapib is a 5th generation CETP inhibitor, right? And not only it lowers LDL, ApoB, it also lowers lipoprotein little a. Only few oral molecules we have in our practice which can decrease lipoprotein little a. And it can be used either as a monotherapy or high intensity statins. It was the first ROSE trial, the phase 2 trial, again the dose finding trial, where with 10 milligram dose you got almost 50% reduction in LDL, which is similar to high dose statins, and also 33%, 56% reduction of lipoprotein little. So this was again a phase 2 trial. So in this CSC they presented two large phase 3 trials, the Brooklyn and the Broadway, combined population of almost 3,000 patients. And again, you can see that almost 70% patients are already on statins. And here they could see that you could get almost 33% reduction of LDL, almost 32% reduction of lipoprotein little. So over and above statins, this molecule produced reduction of both LDL and lipoprotein little. Although they were not CV event driven trials, but again they did record the events, and there was reduction in cardiovascular events also, almost 20 to 30% reduction. So in future, when the molecule comes to the market with 10 milligram dose, you can expect a 33% reduction of LDL, 33% reduction of lipoprotein little a, and almost 30% reduction of non-HDL. ApoB is reduced to a lesser extent. So this pooled phase 3 analysis said that the molecule is safe. It can reduce both LDL, LPA, ApoB, and non-HDL-C. So it's another drug in armamentarium. There's a large cardiovascular outcome trial with the name of Prevail is going on. The third is a drug for resistant hypertension. So aldosterone synthase inhibitors are a new generation of molecules which work in the zona glomerulus of adrenal cortex, and they prevent the formation of aldosterone. We have aldosterone inhibitors, the mineralocorticoid receptor antagonists, but they act as the receptor of aldosterone. Here the aldosterone synthase inhibitors stop the production of aldosterone altogether. So they work very up ahead of the molecule. So baxdrostat is the first molecule. It's given in a single daily dosing. It is 100-fold synthetic for aldosterone synthesis. That means it is not working anywhere else in the body. And preliminary studies have shown that it reduces both plasma and urine aldosterone. The initial dose finding trial told us that you have to use either a 1 milligram or 2 milligram dose. 0.5 is not effective. But the second phase 2 trial was negative, because you can see in the placebo arm also there was almost 14 to 16 millimeter of blood pressure reduction. So probably the trial was not designed properly. So to this, the phase 3 trial, the BAX hypertension trial was designed, where Asia was also a part of it, and they used 2 doses of 1 milligram and 2 milligram. So in the first part, and they included patients with either resistant hypertension or uncontrolled hypertension, and almost 2,500 patients. The primary endpoint was change in systolic blood pressure, and the second, so there was two part of the trials. First, they randomized the drug into the patients into 1 milligram and 2 milligram dose. Then they crossed over everybody into 2 milligram dose, and then they randomizedly withdrew the drug to see that how much days does the effect of the drug persist when you stop the drug. So there are two parts. The first part looked at lowering blood pressure. The second part looked at the sustained effect of the blood pressure. So you can see that there are almost 10 milligram reduction of blood pressure in patients who are already on 3 drugs or 2 drugs. And irrespective of the category in which they were, the molecule was effective. And if you stop the drug also, still at 32 weeks, you still got 5 millimeter reduction of drugs. Then there was change in systolic blood pressure, and there was change in diastolic blood pressure as expected. And even the ABPM result showed that the molecule works. There are no safety signals. So this molecule adds this trial adds another molecule to our kitty, aldosterone synthase inhibitor. There is another molecule, londrostat, is also coming in trials. It has also crossed phase 2 trials. So probably we have a new generation of antihypertensive drugs in the market. With respect to heart failure, two trials are eagerly awaited. The DIGIT trial with digitoxin rather, and VICTOR trial with vericiguat. So we know that there are 4 pillars of heart failure therapy, but what to do when patients is not controlled, or are there some future molecules? So in the DIGIT heart failure, these patients of heart failure with reduced ejection fraction were randomized to digitoxin or standard of care. We all know that digitoxin has been a very old drug in management of heart failure, but probably because of side effects it was not used for the past couple of decades. And this DIGIT trial has brought back again digitalis into a picture. Baseline, both the molecules were matched, and good thing is that many of the patients were on standard heart failure therapy. So beta blocker was in almost 90% patients, RAS inhibitor in almost 90% patients. Only SGLT2 was not probably, because that time it was not probably available or indicated by guidelines, and ARNI in limited number of patients. but you can clearly see that digoxin use led to significant reduction, 18% reduction of events with a small number needed to treat of 22. So digoxin, after almost 2-3 decades of DIG trial, this molecule has shown that digitoxin rather, can lead to prevention of cardiovascular events, and there are no safety signals. So the primary fear when we use digitoxin or digoxin in our practice is a fear of side effects like arrhythmia, etc. But here probably in this digitoxin, with the use of digitoxin, it was well tolerated with current GDMT. So again, another drug is probably added to our armamentarium. We have to wait till the guidelines. Next is verisugat. We all have been using verisugat for the past 2-3 years. It's a soluble guanine cyclase inhibitor, and we have seen in the Victoria trial that it improved outcomes. But Victoria only included patients who had been hospitalized for heart failure. It was not for OPD patients. So Victor trial was designed to see whether the same molecule which worked in patients with recent hospitalization for heart failure will work in OPD patients. Big trial of 6,000 patients, almost 2 years follow-up. The primary outcome was probably negative. There was no statistical significance, although there was 7% reduction in events. The endpoint was cardiovascular death and first heart failure hospitalization. But if you look at mortality, the secondary, it was a pre-specified secondary endpoint. There was significant reduction of cardiovascular death and all-cause death. Very, very surprising that the primary endpoint is negative, but it's strong, because what we want to prevent in any heart failure patient is death. And here both cardiovascular death, all-cause death, and even sudden cardiac death was prevented, and also heart failure hospitalization was prevented. However, the primary outcome is negative, but still I would say that prevention of death in heart failure patients is of paramount importance. So probably based on this trial, both digitalis and verisugat can be an add-on therapies after the 4 pillars have been established. Of course, guidelines, the next year when guidelines will be published, we have to wait what the guidelines are going to say. In acute heart failure, generally we don't SGLT2 inhibitors. It is reserved generally for chronic heart failure, but again, this is the DAPA-ACT trial showing that if you used dapagliflozin in acute setting, there was reduction of events, but it was not statistically significant. Our heart failure hospitalization was significantly reduced. So they combined 3 trials in the pouch which are in acute heart failure for SGLT2 inhibitors in the past 3 years, and the overall meta-analysis show that it is probably effective. So basically, in acute heart failure, when your patient is stabilized, even the guidelines now say that if indicated, you can use SGLT2 inhibitors. That means for diabetic patients or for patients whose ejection fraction less than 40, that recent ACCH guidelines said you should not wait to start, rather you can clearly start. With respect to CAD and ACS, 2 trials I would like to discuss. First is Neo Mindset trial. Normally, whenever we do an angioplasty, the duration of DAPT is always confusion. Some studies say shorter DAPT of 3 months, some studies say shorter DAPT of 6 months, but the standard guideline recommendation is DAPT for 12 months. Now, Neo Mindset trials thought that because the angioplasty or the PCI technology has evolved greatly, and we have now newer generation or more potent P2 vital inhibitors. So can we stop aspirin after 1 month of a PCI? Because we are now completely revascularizing the patient, we are doing imaging, we are doing better techniques to optimize the stent. So after 1 month of a PCI or for ACS, can we stop the aspirin and we can continue the potent P2 vital inhibitor, be it ticagrelor or be it prasugrel. Again, at the primary endpoint was ischemic and bleeding outcome at 12 months. Remember, Stop DAPT 3 trial had last year failed with a similar strategy where they tried to stop aspirin on day 1. Here they are trying to stop aspirin at 1 month, and of course the potent P2 vital inhibitor was primarily prasugrel and limited ticagrelor. You can clearly say that the DAPT arm had lesser ischemic events, although bleeding events definitely were less with monotherapy. So clearly you should not stop aspirin at 1 month after PCI for ACS. So the trial primarily was negative, and even at 12 months the ischemic event rates were very, very high. So in acute coronary syndrome, you cannot stop the DAPT within 1 month of initiation. Rather, you have to wait for at least 3 to 6 months. Beta blocker in MI, with normally beta blockers guidelines say that you should give beta blocker in all patients of acute coronary syndrome irrespective of ejection fraction. But in the past couple of years, there have been multiple trials which have shared if your ejection fraction is more than 50, probably beta blockers don't work. So here there are again 2 trials, BETAMI and DAN block, where again they enrolled patients with ejection fraction more than 40%, and roughly 5,500 patients in these patients in this study, and most of the patients were well treated. Again, if you withdraw beta blocker recently after an MI, then your event rates were higher, all cause mortality was higher, and the event rates were very, very high, and secondary endpoints were also higher. And even in subgroup analysis, there was no subgroup which was showing that we can stop beta blocker. So beta blocker should not be stopped early after an MI, even if your ejection fraction is normal. That is what the guidelines say. To miscellaneous trials, we all know that mavacamten is now in the market. It's been treated for hypertrophic cardiomyopathy. It's a cardiac myosin inhibitor. But Odyssey trial was in patients of hypertrophic non-obstructive cardiomyopathy. That means the gradient was less than 30. The indication for which it is in the market is for gradient more than 30. But this trial tried to see whether even a just hypertrophic heart but no gradient, is it going to work? There was no benefit in both primary or secondary endpoint. The peak oxygen intake, the Kansas City cardiomyopathy questionnaire, none of the parameters improved. So if your patient has non-obstructive hypertrophic cardiomyopathy, don't try to give mavacamten. Another important trial, aquatic trial, we all know that in patients who are already on a stent, who need both oral anticoagulation and P2 vital inhibitor, generally we give only, our guidelines say that we should give only oral anticoagulation. But the trials were not very big. So this was a big trial, or this was a randomized trial to show that in patients who are already on angioplasty and who have another indication for anticoagulation like AF or venous thromboembolism, can we combine both aspirin and anticoagulation? The answer is no, because if you combine both aspirin and oral anticoagulation, your safety, your ischemic events are higher, and your bleeding, there is no benefit. So there is no point in combining both aspirin and anticoagulation in patients who are both having angioplasty and AF. So to summarize, 1 monthly olezarsen has expanded the armamentarium for addressing residual triglyceride risk. Obesity is a new emerging option for LDL-C lowering, and with two positive phase 3 trials. Aldosterone synthase inhibitors is a new upcoming pathway for uncontrolled hypertension in addition to ARNI, zilebesiran or epazotan. Digitalis is back in the armamentarium of heart failure. You can use it as a fifth drug. Of course, you have to wait for the guidelines. Verisuga did not meet the primary endpoint in ambulatory heart failure patients, but did reduce cardiovascular death. The choice is yours. SGLT2 inhibitors now with 3 trials can be safely used in acute decompensated heart failure. You should not try to withdraw aspirin very early after an angioplasty. You should wait at least 3 to 6 months. Beta blockers again similarly should not be withdrawn if you're in a MI patients if the EF is more than 40%. We need to wait for still larger, bigger trials. Mavacamten should not be used when your HCM patient has no gradient. And again, in post PCI patients on oral anticoagulation, there is no benefit of adding aspirin. Thank you.
Thanks, Akshyaya Pradhan sir, for providing the latest update regarding the upcoming trials. Now, if the audience has any questions.
Currently, how you finds the role of vericiguat except worsening heart failure, because it reduces the cardiovascular death. So you still happy to start with 5 pillars of therapy in heart failure therapy or basic, or you will stick still to 4 pillars and use vericiguat in specific situations after this
Personally,
trial?
I was thinking that Victor trial is going to be hugely successful, but because of the primary endpoint is negative, so I'd go with your thought process that I'll first initiate the 4 pillars and then add vericiguat or now I have to also think of digoxin. Of course, the trial was with digitoxin, which is not available in our country. Digoxin is available in our country, so probably I have to rethink. But so I think I'm waiting for more data from the trialist. How come such great reductions in cardiovascular death and still a negative primary endpoint? But yes, it still continues to be 5th pillar. I mean, I'll first use the standard for GDMT and then I'll choose between digitalis and vericiguat. I'll keep vericiguat upper than digitalis because we have been using vericiguat for the past 2 years with excellent results.
And previously, so many 1 or 2 trials, I didn't memorize their names regarding aldosterone synthesis inhibitors. So all are negative trials because of very much higher risk of hyperkalemia and side effects related to that. So what's your message, take on message on that?
Uh, you are talking of aliskiren.
Yeah.
So aliskiren is a direct renin inhibitor. These are aldosterone synthase inhibitors, of course, and now we have three molecules in market in phase 2, phase 3 trials, and the risk of hyperkalemia is not higher than the placebo. And now they have published a clear-cut meta-analysis. The only issue is, to my mind, is that the reduction of blood pressure is to the tune of only 6 to 10 millimeter of mercury. So probably, compared to renal denervation, this appears to be a bit, lesser. But still, I think not everybody can afford a denervation. If your patient is not controlled on 3 drugs or 4 drugs, what the guidelines say we have to follow, then probably this could be an add-on therapy. And maybe the newer generation, because of course Baxdrostat is the first molecule, so people now learn from the mistakes, and probably the newer generation molecules are going to be more potent and more safe.
Thank you, Dr. Pradhan, for your nice lecture.